Hello, everyone, and welcome to this lunchtime neurology webinar on intervertebral disc disease in dogs, brought to you by virtual veterinary specialists. My name is Mark Verrill, and I'm a commercial manager here at VVS. For those of you who don't know about us, we are a multidisciplinary virtual referral service that enables collaboration between vets and specialists. Our aim is to make specialist input easy and accessible. Our flagship services are our live guided cardiac workups and internal medicine workups with abdominal ultrasound. We also offer live guided neurology workups, which can be done from your phone. So if you're ever struggling with a neurological examination or lesion localization in practice, please do get in touch. Alongside the live guided services, we provide advice calls and written reports across multiple disciplines. These services come with 6 weeks of follow-up, which means you and your team have ongoing support as your cases progress, rather than one-off inputs. It's now my great pleasure to introduce you to our speaker today, Dr. Sarah Butterfield. Sarah has done internships at both Langford Vets and Fitzpatrick Referrals. She then completed her neurology residency at the RVC and is both European and RCVS recognized specialist in neurology and neurosurgery. We are very grateful to have Sarah as part of the VVS team, bringing a wealth of experience as well as real enthusiasm and dedication to patient care. If you do have any questions during this webinar, please pop them in the chat box as we go along, and we can answer those at the end. So without further ado, I'll hand over to Sarah for today's talk.
Hi everyone, thanks very much for joining this lunchtime. So today we're going to be talking about intervertebral disc disease in dogs. It's quite a big topic, so we'll be chatting for about 40 minutes, but then we'll have some time for questions at the end. So in terms of the lecture objectives today, we'll be discussing what exactly is intervertebral disc disease. We'll be talking about the different types of intervertebral disc disease that we can get, including their pathophysiology, their typical clinical presentation, how we can treat them and their prognosis. And then actually, is referral really necessary? So when should we refer these patients? What do we do if we can't refer them? And actually, as I said, do we need to, can we manage these cases in first opinion practice? So in terms of our disc disease, we'll start with the terminology. So when people talk about intervertebral disc disease or IVDD, typically people are thinking about that classic sort of acute presentation of a dog off its back legs. But really, IVDD is actually a non-specific term suggesting pathology of the disc, whether or not that's sort of moved sort of beyond its normal anatomical boundaries or just degeneration of the disc itself. When we talk about disc herniation or prolapse, again, it's a fairly non-specific term, but that's sort of suggesting that that disc structure or parts of it have again displaced beyond the normal anatomical boundaries. But when we talk about that classic acute off-back legs presentation, what we're typically meaning is an intervertebral disc extrusion. So that's talking about herniation of the disc, mainly the nucleus pulposus part of the disc, through the outer ring of the annulus fibrosus. Now, in terms of thinking about our disc disease, it's important that we know the anatomy of the disc to really understand it. So we have 4 different regions. As I said, we've got that nucleus pulposus. So that's the squidgy center, and it's surrounded by a thick outer ring. So that's the annulus fibrosus. Between those is known as the transitional zone. And then we've got our cartilaginous end plates, which attach each disc to the vertebra. And we have discs between all the bones of the vertebrae throughout the vertebral column, and it's aiding sort of stability of the vertebral column. Now, the only one that doesn't have it is the first 2 joints, so between C1 and C2 bones of the spine. Now, in terms of how many types of disc herniation do we have then? So obviously we've mentioned one, the sort of the classic disc extrusion, and you might think, is there another one, maybe two? But actually we have about six sort of well recognized and described types of disc herniation, maybe even seven. So in terms of the talk today, we'll go through the three main ones because that's all we'll probably have time for. So as I mentioned, we have our disc extrusion, also known as a Hansen type 1. So Hansen is someone who first described this type of histopathological degeneration within the disc. And so we have an extrusion, and a Hansen type 2 is known as an intervertebral disc protrusion. And we go into a bit more detail about the difference between those two. There's also something called DEEH, which means and stands for disc associated extensive epidural hemorrhage. So this is bleeding associated with a disc extrusion that's been sort of more recently described. And then the third one that we'll talk about is an ANNPE, so acute non-compressive nucleus pulposus extrusion. So as the name suggests, this happens very acutely. It's part of the disc is the nucleus pulposus that extrudes, but it comes out very quickly and causes more a contusive lesion to the spinal cord rather than compressing it. So it's also been termed a high velocity, low volume disc extrusion. What's incorrect is calling it a Hansen type 3 because we don't see the same type of degeneration associated with that. So we don't call it that. The other types of discs that I mentioned, so there has been something called hydrated nucleus pulposus extrusion. So again, as the name suggests, that material is hydrated, so it's more sort of got a more higher water content, and it has very kind of particular MRI imaging findings. In terms of how they differ clinically, quite often those dogs are less painful, and it has got a predisposition for the cervical region. So often those dogs are tetraparetic or even tetraplegic. We can also see what's called intradural or intramedullary disc extrusion. So if you remember back to your anatomy days, surrounding the spinal cord, we have three distinct meningeal layers. The outer and thicker most layer is the dura or the dura mater. And so when we see intradural, we mean the disc has actually penetrated that dural layer, and intramedullary actually refers to being in the spinal cord parenchyma itself. And then for a traumatic disc extrusion, as the name suggests, it's associated with some kind of traumatic event. So something like a road traffic accident or falling from a height. And then I've also mentioned just the FCE, so fibrocartilaginous embolism or embolic myelopathy. So technically, that means a bit of disc material is usually what's been found to have blocked one of the vessels to the spinal cord and causing a massive ischemic event to the spinal cord. Now, I mention it, but it is actually a diagnosis made post-mortem. So really, we don't tend to use the term FCE anymore if we're making this diagnosis ante-mortem, and actually tend to use more the umbrella term of an ischemic myelopathy, because we can't actually prove that it's fibrocartilaginous material that's caused that embolic event. So in terms of going on to our specifics, so we'll start with our intervertebral disc extrusion. So our most common presentation that we see usually in the neurology team. So this is when we get an extrusion, as I said, of that nucleus pulposus, which is quite calcified and degenerated material through a rupture in that thick outer ring of the annulus. And when it extrudes, it typically goes into the vertebral canal, which is lying over the top of the disc and causing the clinical signs associated with compression of the spinal cord. So this is typically our chondrodystrophic breeds. So usually it was our Dachshunds. But of course, the great popularity of the French Bulldog has probably overtaken them now, and we see Frenchies a lot, as well as other dogs like Cocker Spaniels, Cockapoos, Beagles, Basset Hounds, Corgis, Pekingese, all those dogs with short little legs and long bodies. It's also worth noting it can occur in cats as well. Around the thoracolumbar region is quite common, although dogs like Cocker Spaniels are seemingly predisposed to lower lumbar disc extrusions. And then the clinical signs relate to that site of the extrusion. So they can be neurologically normal, just with pain. to complete lack of movement, so paraplegic, or if in the neck, even tetraplegic. And when we talk about their classic clinical presentation, we can use what we call this five-finger rule. So we can describe them as typically an acute onset. They usually have progressive signs. They're usually painful, associated with a disc extrusion, quite often symmetrical, but they can also be quite lateralized in terms of their signs, i.e., one leg worse affected than the other. And then, as we said, sort of localization depends where that disc extrusion has happened. And then this diagram just shows that sort of soft center has extruded out of the annulus. And it's the most common neurological presentation in Frenchies, according to this particular study. So as I mentioned, that rule of six, so we can use our clinical reasoning to, this mainly applies in the paper that it was described in from the RVC to thoracolumbar lesions, but really it can apply to a lot of neurological presentations. So we say rule of six or even the five-finger rule, so one being kind of the signalment. So age and breed are very important in terms of what we think might be going on. But then we talk about the onset. So whether that's peracute, acute, or chronic, our progression, so whether that's improving, static, deteriorating, asymmetry, one side more affected than the other, pain, if that's present or not, and then, as I said, our neurolocalization. So, as you said, for the history taking, that's where you'll get the information for the onset and progression. And knowing that from the owners is going to be really important in terms of determining what differential diagnoses are most likely. So, this diagram is just taken from the BSAVA Neurology Manual, and it shows quite nicely sort of how things tend to progress with time. And so that's when we talk about our differentials and remembering our damn it V to kind of what we think could be going on and what we think is most likely. And then, as I mentioned, in terms of sort of their onset per acute, we're really talking in a matter of seconds. So this is typical for our ANNPEs and our ischemic events, so our vascular events, and obviously trauma as well. Acute is usually meaning a few days, and that's typical of an intervertebral disc extrusion. And then chronic is more typical of a disc protrusion. And then when it comes to performing our neurological examination, so that's when it's going to tell us about the asymmetry, the pain, and the localization. And so if we just go over very quickly some main points from the neuro exam. So of course, first of all, we talk about our posture. So if we're talking from a spinal point of view, we might see a low neck carriage with a cervical lesion if they're painful in their neck and unwilling to move it. We might see kyphosis with a thoracolumbar lesion again, so they've got spinal pain. And we might see specific postures such as Shift Sherrington. So this is when we see rigid extension of the thoracic limbs and typically sort of loss of tone of the pelvic limbs. And usually these patients are paraplegic because they've had an acute and severe thoracolumbar injury. And then when we talk about our gait, we're talking about paresis or plegia. So if you guys remember, paresis being weakness and sort of reduction of movement versus plegia being complete loss of voluntary movement. And then it depends on which limb is affected. So para being both the back legs, tetra being all four. So we could be paraparetic, paraplegic. And then we talk about our upper motor neuron versus lower motor neuron as well. So upper motor neuron being they have good tone of the limbs and intact spinal reflexes, and lower motor neuron being they've got reduced tone and perhaps reduced or absent spinal reflexes. And then we talk about our ataxia. So if you remember, we have three different types of ataxia in neurology. So of course, vestibular and cerebellar are to do with the brain, so not to do with what we're talking about today. But what we typically see with the spine is a general proprioceptive ataxia. And then we can use this score. So this is a modified Frankel score, talking about the degree of spinal injury. So I tend to use it this way round. So one being neurologically normal with spinal pain only, all the way down to five being paraplegic with absent deep pain perception in both limbs and tail, i.e., you clamp those toes or the tail with your artery forceps, and you get no voluntary response that that dog can feel what you're doing. So, as I said, just in terms of our localization, of course, we have different areas of the brain, and we also have the neuromuscular system, so our peripheral nervous system to do with the muscle nerves and neuromuscular junction. But for the sake of today's talk, we're talking about the spine. So, if you remember, we have our different parts of the spinal cord segments that we can localize to. So, we have, if all four legs are affected, we know it's going to be C1, C5, or C6, T2. And if it's just the back legs, we know T3L3 to L4S3. And then we use our spinal reflexes. So that's typically taking the withdrawal reflex in all four limbs, as well as the patellar reflex in the pelvic limbs. And if they're intact, we know that over the forelimb sort of intumescence and then the lumbar intumescence. So over those two limbs, if they're intact, then we know it must be either a C1, C5 or a T3L3. Now, just to remember, there is this neurological phenomenon known as spinal shock. So this typically happens when we've had, again, an acute and severe thoracolumbar lesion. So it's a T3L3 lesion, but sometimes we can see reduced spinal reflexes with that because we see a temporary loss of the reflexes that can take a few days to return. And so occasionally that can just confuse you a little bit. But we can actually see disc extrusions in the neck as well, and they can present in similar ways in terms of paresis and even tetraplegia. But it's worth noting that they can just be very painful. And what's quite typical, particularly in French bulldogs, I tend to find is that they have this really marked cervical pain that can be really episodic. So they can be trotting around absolutely fine and then screaming. And they can also have these very marked muscle fasciculations in the neck as well. And they almost look like they've got these myoclonic jerks. So they look like they're having electric shocks because they've got this such significant pain in their neck. And this was the same patient, sort of adopting actually quite a kyphotic posture. So he's quite hunched in his back, but he was also very low in his neck carriage as a result of the neck pain. And if I just try and play this video for you guys again, so you can just see how this little Frenchie is having sort of these brief shock-like movements. This dog did end up actually having surgery, so he had a ventral slot, and that was him the following day. So he was very happy, sort of just a day after surgery. So they don't always have to have neurological deficits. And then I mentioned on our first slide, we can see this extensive epidural hemorrhage associated with disc extrusions. So this is thought to be a result of sort of laceration of the vertebral venous plexus when the disc material extrudes out of position. And it can sort of add to the spinal cord compression as well as the disc material itself, or even cause a sort of focal hematoma, typically in the thoracolumbar region, and often these medium to large breed dogs have been described with it. So sort of Labradors, German Shepherds, but it has also been documented that Frenchies are overrepresented with this presentation as well, and they can rapidly progress to becoming very severely affected, so paraplegic. And again, they typically have this acute onset, progressive, markedly painful myelopathy, depending on where the bleeding has occurred. So then in terms of treatment for disc extrusion, so of course we have either medical or surgical treatment, and what might be indications for surgery and probably referral if that's the case. So usually these dogs have failed medical management or they have persistent pain despite sort of multimodal analgesia. They've got progressive clinical signs, so they're worsening despite sort of being rested and with pain relief. Severity, so quite often the non-ambulatory dogs are those that are ones taken to surgery, and also dogs that have had sort of recurrent events. So this is not, their first presentation for these signs. And then, depending on sort of how severely affected these dogs are, can depend sort of prognosis wise on whether they have medical management or surgery. Now, you can see from this table that's taken from the ACFIM consensus statement on diagnosis and management of acute disc extrusions in dogs that actually even if these dogs are non-ambulatory, they can still do very well with medical management alone. So they don't necessarily need it. And even if they're paraplegic, so complete lack of movement, but they have that deep pain perception, again, these dogs can still do pretty well with medical management. Of course, they tend to do better. They tend to recover quicker, less likely have a recurrence if they do have surgery. But the main sort of factor that we tend to consider that affects the prognosis is that presence or absence of nociception, i.e., that deep pain perception. And you can see from the table there that the likelihood that these dogs are going to recover really goes down if they lose that deep pain perception and they are medically managed. So if they're deep pain negative, then usually we're quite keen to perform surgery on these dogs. Other factors what you might consider, so potentially the breed. Sometimes we do feel like some dogs don't do as well, for example, Frenchies. And if they are an L4S3 localization rather than a T3L3, again, they don't tend to do as well. And then in terms of treatment, so what do we mean when we talk about medical management? So we're talking analgesia. Typically, these dogs are going to be painful, so non-steroidals, gabapentin, paracetamol are all sort of reasonable first-line analgesics, and opioids if they're hospitalized for a few days. So even if they are screaming in pain with a neck disc, if you hospitalize them for 24, 48 hours with some opioids, these dogs can feel markedly better and you sort of stop the cycle of the wind up pain and you get on top of it and they can still do really well. So sometimes a couple of days is all they need initially with the strong pain relief and then sort of a couple of weeks worth of at-home medication as well. If they've got those kind of muscle fasciculations associated with it, something like a muscle relaxant might help. So something like diazepam or methocarbamol might be used. Exercise restrictions. So typically we mean a minimum of 4 weeks, ideally in a crate, if not kind of restricted to a small room. Avoidance of these high impact activities. So avoiding these dogs trying to jump on and off things, going up and down stairs. And the reason that we say 4 weeks is usually that's sort of an accepted time for the annulus fibrosis to sort of heal again. So that's why we tend to kind of consider that amount of time. If they're recumbent, they'll need frequent turning to prevent horrible ulcers forming and skin lesions. Physiotherapy and hydrotherapy can be helpful as well, and a lot of those kind of basic physio exercises can be performed by the owners at home. And then bladder management is a big one as well. So typically these dogs that are paraplegic are going to have this retention incontinence. So either they are being expressed at home twice, 3 times daily. They might have a urinary catheter placed if you're hospitalizing them. And then they might even have something like a cystostomy tube. Of course, this is a temporary thing, but they can be placed for, a number of weeks whilst we're hoping for signs of recovery in these patients. And it's also worth noting that the spine might not be the only problem. So, of course, we see a lot of French bulldogs, and a recent study actually found that 1 in 5 Frenchies that are presenting with disc extrusions have respiratory compromise, where a proportion of these dogs need emergency management, including sort of immediate anesthetizing and intubation or even a trach tube in the worst case scenario. So even if these dogs are paralyzed, you need to, of course, manage the any comorbidities sort of in the immediate setting. So, what if referral is not an option? So, as you said, medical management is ideal for these dogs presenting painful or ambulatory para or tetraplegic, and intervertebral disc extrusion is deemed the most likely diagnosis. But what do you do if that dog is severely affected, i.e., they're deep pain negative, for example? So I wanted just to highlight this paper that came out recently from Cambridge. So This is to do with small non-brachycephalic dogs. So the majority of these dogs in the study were little miniature dachshunds, and they were conservatively managed for an acute thoracolumbar disc that was diagnosed on MRI. And actually, you can see that 48% of these deep pain negative dogs did recover ambulation within their 12-week study period. So it was quite an interesting finding because previously we thought the prognosis would be significantly worse. So it's not the be all and end all. If you've got a particularly dedicated owner that's willing to sort of give them the time, then it is possible. If you are going to manage that condition, however, you need to be aware of this potential complication. So this is called myelomalacia, or progressive ascending descending myelomalacia, so sometimes called PMM. Now, this is a complication that's typically seen in deep pain negative dogs. So the dogs that have got the worst level of spinal cord injury. So it's usually about 10% of those grade 5 dogs. In one study, is up to a third of French bulldogs had this complication. And essentially, what it is that the spinal cord has undergone an initial primary injury, i.e., the disc has come out of place and hit the spinal cord, but then that set off sort of a cascade of events, and that's what we call the secondary injury to do with sort of the edema, inflammation, etc. And then we get this death of the spinal cord and necrosis that essentially sort of just keeps spreading from the initial site of injury up and down the spinal cord, and it's potentially more likely with sort of lumbar intumescence lesions. But unfortunately, what happens is from that initial site of injury, the spinal cord just becomes progressively necrosed, and therefore we see clinical signs suggestive that the injury is moving. So these dogs can suddenly become very painful. You can see upper motor neuron to lower motor neuron signs, so the legs become flaccid when they were previously had good tone. Quite often we start tracking their cutaneous trunci. So if when you do your neurological exam and you pinch the skin on the dorsum and you usually have sort of cut off of the cutaneous trunci, if actually when we have these deep pain negative patients, what we tend to do is we make a mark on the skin each day where that cutoff is, because actually if we see that it's progressively tracking forward, then we would be concerned for this complication. Then you tend to see a loss of abdominal tone. These dogs then, if they're paraplegic, they struggle to right themselves in their thoracic limbs because actually they've become weaker as well. And then eventually you can see Horner syndrome. So sort of what you can see in this dachshund in the picture. And eventually it will affect the respiratory system and the respiratory drive. So if you leave them long enough, unfortunately, these dogs will die from hypoventilation. And sadly, this condition is thought ultimately fatal. So if you have these sort of myriad of clinical signs that are suggestive in a deep pain negative patient, then usually the kindest thing to do, unfortunately, is euthanasia, because ultimately it's not a particularly nice way to go. So on to our second disc herniation, so our intervertebral disc protrusion, or our Hansen type 2. So in this one, instead of the nucleus pulposus extruding out, we have fibroid nuclear material sort of extending between the fibers of the annulus fibrosus that's surrounding the nucleus pulposus and resulting in its thickening. And what we usually tend to see is this dorsal protrusion of the annulus, again because the spinal cord is overlying the disc. Then we see this protrusion and chronic sort of compression from underneath of the spinal cord. Now, this is typically our non-chondrodystrophic breeds that are a bit older, so usually over 7 years. So these are things like, again, Labradors, German Shepherds, and quite often because they're more chronic and slowly progressive, they have milder neurological deficits because the spinal cord can sort of compensate with this slower disease process. Quite often, multiple disease discs are affected as well. And we can see a protrusion as part of sort of a described sort of separate clinical entity. So one called degenerative lumbosacral stenosis or lumbosacral disease, and also as part of disc-associated cervical spondylomyelopathy or sort of Wobbler's syndrome. And again, as we said in the diagram, we can just see that it's that dorsal protrusion of the annulus fibrosus. Again, in terms of treatment, if we're talking medical treatment for disc protrusions, again, we can talk about analgesia as required. Occasionally, we might consider the use of corticosteroids. So, corticosteroids are contraindicated in acute spinal cord injuries. If anything, they have actually been found to be detrimental. So, we don't tend to use them for the acute injuries, but certainly for the more chronic ones where there's an element of spinal cord edema, then certainly a short course of corticosteroids might help. In terms of exercise, so it's sort of managing these patients, avoiding things like high impact activities, again, that might exacerbate their clinical signs and make them acutely worse. And again, things like physiotherapy and hydrotherapy in the long term can be helpful for these patients as well. And then lastly, we'll just talk about our ANNPE, so our acute non-compressive nucleus pulposus extrusion. So as we said before, this is a rapid extrusion of non-degenerated nucleus pulposus. And so what happens, as I said, is a little bit of this material sort of pops out at a very high speed, and the injury is caused by the spinal cord contusion as it hits the spinal cord. But as the name suggests, it doesn't really compress the spinal cord. And so surgery is not going to help these dogs because there's actually not really anything to remove in terms of disc material. Typically, we might find that these dogs have a clinical history of exercise or trauma due to these sort of supraphysiological forces applied to the vertebral column. The thoracolumbar junction is a very common site for this to happen at. Quite often, you might hear vocalization at the onset, but then from there, usually these dogs are non-painful. Very common to be lateralized, so one leg sort of significantly worse than the other. And that's also reported in the longer term urinary and fecal incontinence in a good proportion of these patients as well. So just on to case 3. So this is a 9-year-old male neutered greyhound who was completely normal on the morning of the walk, went out for a walk, ran after a bull. The owners reported that the dog yelped out at the time and then was immediately down and unable to walk. With some support, they sort of managed to get the dog into the clinic. They don't find that the dog is particularly uncomfortable now. But as you can see from this video, these dog signs are markedly lateralized. So there's quite minimal movement in that right pelvic limb, but the dog is actually basically walking on the left. The thoracic limbs are normal. So in terms of using our 5-finger rule again for this patient, so what we would call that is happening in a couple of seconds. We know it's a peracute onset. This dog hasn't particularly worsened, so we say non-progressive, non-painful, right lateralized, and again, this dog localized to a T3L3 myelopathy. So had proprioceptive deficits in the pelvic limbs, but intact spinal reflexes. So intact patellar and withdrawal reflex, and we localized to a T3L3. So this presentation is really typical of an ANNPE or an ischemic myelopathy. So what we talked about earlier in terms of an FCE. So these two have a very similar clinical presentation and actually sort of treat them in a very similar way. So if we're talking kind of a presumptive diagnosis, then it doesn't necessarily matter, but they typically present again this peracute onset, non-progressive, non-painful, and quite often lateralized myelopathy. It's also worth noting that again with a peracute onset, as we said, a fracture luxation is a big differential. So if there's anything unusual in the history, such as the dog has gone out of sight, and something potentially could have happened, then it's just worth noting that is possible before you start doing too much of a neuro exam. So, in terms of how might we differentiate between ANNPE versus an ischemic myelopathy? So, clinically, there was one particular study recently that's talked about these clinical factors between the two. So, border collies have been overrepresented with ANNPEs versus the ischemic myelopathies, whereas staffies were overrepresented with them. We talked about vocalization at onset, so that's quite typical for an ANNPE and often associated with exercise. Um, uh, Quite often, spinal hyperesthesia might be present more so in an ANP versus an ischemic, but as I said, quite often both of them are non-painful. The thoracolumbar region is most common for both, but if you're sort of comparing the two, maybe we see an ANP more so in the C1, C5 region compared to an ischemic myelopathy. And also, these dogs are more likely to be ambulatory at discharge. Now, depending on where you read which sort of paper, generally these dogs have a good prognosis in terms of recovering ambulation, so kind of 60 to 90% or so. However, persistent motor deficits are common, so usually it's the most severely affected limb. We might see sort of persistent deficits in, as I mentioned as well, even 20 to 30% or so ongoing fecal incontinence has been reported. That is more likely in those dogs that are initially paraplegic. And as we said before, in terms of that deep pain perception, again, that's a very important factor in these dogs because actually, if they're deep pain negative, typically we consider a less than 10% chance that these dogs are going to recover ambulation in that limb or both limbs if they have lost that deep pain sensation. And as I said, do not forget the possibility of a fracture luxation because with a peracute onset, inability to walk on the back legs, it is possible, even if they've just gone off somewhere for a few minutes on a walk. If there's any sort of unusual thing in the history of just any inkling, it might just be worth taking a quick lateral x-ray before you start moving these dogs around too much and even strapping them down to a spinal board if you're unsure and taking a quick lateral x-ray because I did have a very similar case that was actually just out on a walk, went in a bush for a couple of minutes and the owner found the patient. We said, let's just take a quick lateral x-ray before you refer this dog in. And this was that patient's X-ray. So unfortunately, as you can probably see at the thoracolumbar junction, we have a massive luxation there. Unfortunately, this dog was deep pain negative, i.e., that entire spinal cord has been transected. And in that scenario, again, the kindest thing to do really is euthanasia. So if we start talking about the treatment for an ANNP, as you said, because it's non-compressive, then surgery is not really going to help these patients. So it's really always medical treatment. Because they're not typically painful, analgesia is not usually required. However, in one study, the use of NSAIDs after the initial diagnosis was associated with reducing the chance of long-term fecal incontinence. And so it might be that we consider their use. So I typically do give dogs with an ANNP a short course of NSAIDs. Exercise restriction, a slightly controversial topic, I suppose, because if we are thinking with an NMP that there is a rupture in the annulus fibrosus, as we mentioned before, we probably want to arrest these dogs for 4 weeks. However, again, a recent study has found that it's not really been associated with not recovering as well or occurrence of signs. So yes, I do tend to rest these dogs, but I don't typically sort of crate rest them. Again, avoiding high impact activities, sling support as required because as we said, quite often these dogs, if they're markedly lateralized or unable to walk, we do want to get them up and about and encourage them to use those limbs. So you can use a sort of a little harness for the back end or all four limbs if all are affected to sort of get them up and about. Protective booties might be needed, as you can see in this image. This dog would just drag the most affected limb, and of course, what we don't want to do is cause any sort of iatrogenic damage to the affected paw. So booties is needed, and physiotherapy, hydrotherapy again are going to be really paramount to these dogs' recovery, and something that the owner can do at home. And again, our bladder management. So if these dogs have movement, typically the bladder is not affected. So usually we're seeing sort of inability to urinate, say, in the dogs that are paraplegic. And so if they do have good movement, then it's quite unusual that we're having problems with urination. But teaching owners sort of bladder management and expression as well is part of their management as required. So that's all we've got time for today. So thank you very much for listening. And please do let me know if you've got any questions. And as Mark said, we've got we're very happy to take consultations with the neurology service at VVS. So we're happy to talk about anything. So please let us know if we can help at all.
Thank you, Sarah. That was a very interesting talk. We We're just waiting for some questions to come in. While we are waiting, I just wanted to actually ask with regards to the live guided neurology workups, what kind of cases do you think would benefit from those live guided
So
exams?
we're happy to help with any, I suppose, in terms of the live guided workups themselves. So if you've got any patients that you are a bit unsure regarding localization, or actually you just want to practice your neurological examination and get a bit more comfortable with performing it, then we can talk through the case. What we will do is have you guys on a camera at the other end. So if you are examining your patient, if you've got someone just to help hold the camera, and then we'll talk through the examination and talk you through the findings and then the localization as well. So really it covers all bases, I guess, in terms of localization and types of cases. But I suppose most commonly things to do with the brain, cranial nerve abnormalities, disc disease, the spinal patient spinal patients, and also things like neuromuscular disease as well. So don't forget those. They can be a bit tricksy as well sometimes. If you do have patients that are normal on their neurological exams, but they're doing weird things in between, but they're always normal when they come into you, of course, it can be frustrating. But if you're happy to take some videos or ask the owners to take videos, then as part of our consults, we can also look at those videos for you as well, and sort of take it from there.
All right. And then we've got some questions come in. First question is there any evidence that intravenous fluid therapy being useful in initial management?
I suppose it's not a huge amount of evidence, but I think what we do know in terms of spinal cord injury is that, and the same applies to a traumatic brain injury as well, is that we need to make sure that these patients are adequately perfused because hypoperfusion will contribute to that secondary spinal cord injury that we mentioned. So, whilst in a normal perfused patient, then I suppose it might not be the most helpful, but we need to make sure that these patients are, yes, not being hypoperfused essentially. So making sure that they've got adequate blood pressure, adequate oxygenation. So whether or not that means sort of requiring oxygen as well, again, that's typically for the brains. But if there's any doubt, then yes, I do give these patients fluid therapy. I think it's also a bit easier if you do have a patient that's recumbent with, say, a urinary catheter in place, you can kind of match the ins and outs of fluid therapy with the urine output as well.
Okay. And then how do you differentiate upper motor neuron from lower motor neuron? That's the next
Ah,
question.
yeah. So that's, I guess, a bit of a big topic. So I guess in terms of lower motor neuron, if we're talking about the spine, what we mean is those intumescences. So the big, lots of nerves coming to the thoracic limb or the pelvic limb are affected. So that's a region of C6, T2 or L4, S3. So if they're lower motor neuron, if they are ambulatory, typically those dogs have a very short strided gait rather than the upper motor neuron gait is typically they have a kind of a longer, more floating gait as they're walking. They can have reduced tone in the affected limbs. So if you feel, it's usually easiest to feel the dogs when they're in lateral. And if you feel kind of thoracic compared to pelvic, and one side compared to the other, and just sort of get a sense of, I guess, resistance in the limbs in terms of tone. And then regarding your spinal reflexes, then usually, as I said, the most common and easiest to perform are going to be with your withdrawal reflexes. So if you pinch the toes, then you should get a reflexive movement, flexing all the joints of the limb, all the way up, in each limb. And then on the pelvic limbs, you can do the patellar reflex as well. So if they are upper motor neuron, they should have good tone, intact spinal reflexes. If they're lower motor neuron, they have reduced or absent limb tone, and they have reduced to absent spinal reflexes, if that makes sense. And it can also affect the bladder as well. So I guess an upper motor neuron bladder is one that typically fills, but they can't release. So it just gets bigger and bigger, and they can be quite firm and turgid and difficult to express. Whereas a lower motor neuron bladder is typically a bit more flaccid, easily expressible, and they might sort of continually leak urine as well. And so that's how they tend to differentiate clinically.
Perfect, thank you. And then on the bladders, we have another question. When do you start to reduce bladder expression to observe if the dog may urinate by themselves?
Yeah, I think that's always a slightly tricky one, because of course, if you just keep expressing them, then you won't be able to tell. What we want to really look for is to encourage these dogs to urinate voluntarily. Of course, as soon as possible, but take them out very frequently. See that they are sort of sniffing around, looking for a spot that they it shows that kind of voluntarily wise want to urinate. Usually, I would try and give them, if you're trying to wait and see, probably at least kind of 12 hours or so, but make sure that you're keeping an eye on the size of the bladder, because if not, you do want to be really expressing these patients, if they can't, at least twice a day. If you leave it too long, then the bladder can sort of obviously get bigger, and then cause detrusor atony. So sort of basically damaging the muscle of the bladder itself, and causing problems from that point of view. So I yeah usually give it kind of 12 hours or so, and get these dogs out frequently, and just spend some time with them outside.
Mm. Thank you. And then a question, corticosteroid use in both Hansen 1 and 2, why or why not?
Why or why not? So there have been a couple of studies talking about corticosteroid use in an acute spinal cord injury. So typically thinking Hansen type 1 disc extrusion, as well as things like traumatic brain injuries as well, and found that they are not particularly useful. And although you might think, oh, there's probably a lot of inflammation, edema associated with it, actually, we don't tend to recommend their use with an acute spinal cord injury, whether that's a disc extrusion or something else. Um, the reason in Hansen type 2 is that because the spinal cord is more chronically affected, we can see different changes within the spinal cord itself. So we can see something called gliosis, and edema associated with kind of that real chronic compression. So when we scan these dogs, we can see that their spinal cord is so compressed, but they're still walking around because they've managed to kind of compensate over time. Whereas if that level of compression had happened acutely, those dogs would be, off their legs. So because of that kind of chronicity, then it might be a bit clinician dependent. Some neurologists might not like to, but I've certainly used some steroids in the more chronic cases. Try not to use them long term, of course, because they're associated with their own side effects. But short term anti-inflammatory doses can help these patients.
Perfect, thank you. And then last question, does progressive only refer to worsening? And also, if you have a case that is improved by the time you first see it, do you say non-progressive or improving or something else?
I suppose if the dog has improved by the time you see it, I would say improving. If they have not deteriorated, but they've not really shown any signs of improvement, then I would just call them static or non-progressive, if that makes sense. I hope that
Okay.
answered the question.
And then if you have time for a final question, do you have a favorite NSAID? Because Colin sees many GR reactions to some of the drugs. So do you have a favorite NSAID that you use?
Um,
Or are we even allowed to answer that, I suppose? Probably
Well, I'm
not.
I'm sure it's fine. To be honest, I still personally just use meloxicam a lot. I don't often find, of course, I'm sure you do get GI reactions, for sure. And if one doesn't work, then usually if I want to give them and think they'd be beneficial, then use then have a suitable washout period and then perhaps try another one. If the GI side effects were really awful, hemorrhagic, diarrhea, then I'd have to weigh up the benefit of trying a different NSAID with the risk of that happening again. So I guess a little bit case by case, but I suppose my typical go-to would be meloxicam.
Perfect. Oh, that's all the time for questions today. Thank you so much for everything. That was a really useful talk, and